I am Paige Seabrook. I am currently a third-year MedPeds resident at the University of Tennessee Health Science Center in Memphis, Tennessee. And today I am talking about a case report called the Maddening itch, a case of acute cholestatic hepatitis from EBV infection. The learning objectives here are just that learners should identify both the common and uncommon presentations of acute EBV infections in adults. And then also learners should develop or create a prioritized differential diagnosis for a patient that is presenting with a new acute cholestatic liver injury. Introduction. So we know Epstein-Barr virus, commonly called EBV. It's a very common virus and affects like up to 95% of the world's population. Typically, the presentation of EBV is actually pretty variable, but typically what we see is the fever, the exudative pharyngitis, and then the lymphadenopathy that we all learn about medical school. Actually, liver involvement with acute EBV infection is actually pretty common, but a lot of times we don't see it because we're not necessarily checking labs when these patients present. But actually up to like 80 to 90% of infected persons will show like mild liver enzyme elevations. But within that population, less than half of those people with liver enzyme elevations will show a cholestatic injury. So that's characterized by an elevation specifically in the alkaline phosphatase, the GGT, and the total bilirubin. So our case presentation, we had a 33-year-old previously healthy female that came into our MedPeds general medicine clinic and with presentation of just intractable itching. She had no past medical history and only medications included a Zyrtec that she took daily. She was already on that medication prior to this chief complaint, and then just as needed ibuprofen and acetaminophen. The itching started 2 days prior to presentation, and it never was associated with a rash. And just on review of systems, other things included just some mild cervical lymphadenopathy that she noticed. And then she did report one episode of a self-limited vomiting, fever, and rigors 1 week prior to the itching started. She said there's no pharyngitis, no fevers, and no fatigue. Her vital signs were all within normal limits, so no fever. Physical exam, she was not jaundiced, and she had no pharyngeal exudates. Really, her throat was very benign appearing, and no hepatosplenomegaly on exam. She did just have some very, very mild submandibular lymphadenopathy. With this presentation, we discussed a differential, and top one was kind of a cholestatic pattern of hepatitis, giving her acute pruritus with no rash. And so that includes both an infectious cause and then also can include autoimmune reasons. But also we had on our differential different drug reactions and then a possibility of a malignancy. The first thing we did, we checked labs in clinic. So we got just a normal CBC and a CMP. So if you see the lab table on the right, her AST was significantly elevated, ALT was elevated, ALK phos was very elevated at 681, GGT as well, and then a total bilirubin that was at the top end of normal. At that time, also, we got an anti-mitochondrial antibody to rule out the autoimmune causes, and that came back negative a day later. We sent her immediately to get an abdominal ultrasound once we saw the elevations in liver enzymes, and all it showed was just mild splenomegaly, but no gallbladder or hepatic pathology. So once we followed up on the read of the abdominal ultrasound, we started considering Epstein-Barr virus as a potential cause. So then added all of these labs, as you can see in the chart as well, to test for mono. She did have a positive mono spot test. And then we had an EBV titer panel come back, and we had a positive IgM and positive IgG to the viral capsid antigen. So that confirmed our diagnosis of an active EBV infection. Our hepatitis panel came back negative after that. So management and outcomes. So at that point with our lab values and our ultrasound, we did make the diagnosis of an acute cholestatic hepatitis secondary to acute EBV infection. The patient's itching actually improved with doxepin we prescribed. And she otherwise just clinically kind of improved with time after 3 days. And then we saw her back in clinic and she had complete normalization of all of her lab values. So here in the second column is the all of her values at follow-up. She did, which was interesting of note, she did begin showing signs of a classic EBV infection about 1 week after the initial presentation of pharyngitis, and reported pharyngitis, fatigue, and some mild low-grade fevers. So we wanted to do this case report because it represents an uncommon presentation of acute EBV and should remind us in primary care to keep that on the differential whenever we have anyone coming in for acute pharyngitis. And then something to remember too, early ordering of EBV serologies can actually lead to a pretty quick definitive diagnosis. And then we can save the patient from unnecessary testing after that. So an approach to a patient with this type of acute cholestatic hepatitis should include always a detailed medication reconciliation to include any kind of drug-induced hepatic injury. So you specifically want to ask about things like acetaminophen, obviously, and herbals. And then imaging to assess for any structural or functional etiologies, such as any gallbladder disease. And then also thoughtful ordering of infectious labs, including a hepatitis panel and EBV titers. And that is it I have. Thanks.
Perfect. Thank you, Paige. Just for the audience, what will be one brief summary of the case report that I want everyone to take away from your presentation?
Yeah. So to always keep in mind with the patient who presents pharyngitis that EBV can actually present like this. And the patients don't always have to have the typical pharyngitis, fever, and lymphadenopathy. So to keep it on the differential, and ordering EBV panel is actually pretty easy. It comes back quick and it can give you a quick, easy, definitive diagnosis.